Everyone. I welcome you all to yet another episode of Vodcast brought to you by ICCM. This is your host, Dr. Monalisa. I'll be co-hosting this session with my colleague, Dr. Jaicob Varghese. So today we are going to talk about end-of-life care and limitation of life-sustaining therapies. And we have among us Dr. R.K. Mani, who has been the past president of ICCM. Sir has also been on the forefront of formulating the policies and guidelines about end-of-life care practices in India. Sir is a clinical director of critical care and pulmonology in Yashoda Group of Hospitals, Kausambi, Ghaziabad. I welcome you, sir.
Hello, everyone.
Welcome you once again. As Dr. Monalisa pointed out, sir, as trainees and most of the listeners have started getting information about end-of-life care from your lectures and classes right from many years. Because you have been in the forefront in framing end-of-life policies in India for irreversible and debilitating disease almost 2 decades. So could you please give a brief outline how there has been a change in policies from 1990s to the current decade?
Yes, you see, in the world, after the romance of resuscitation and then life-saving interventions and the sudden ability to change the scene for those who were previously given up for good, for lost, that shifted. Perhaps in the 70s, early rumblings were there. Then it gathered speed in the 90s that we must have, together with all these advances, a mechanism also to limit treatment. Because like anything, you have a ethical framework for any intervention. So where it will not help, it would harm in various ways. It would harm the patient, it would harm the families, not only physically, but also emotionally and spiritually and financially. So these burdens we had to do something about. So they started, the thought process picked up speed in the 80s and 90s, and then now it's relatively much easier in the Western societies where intensive care is well developed to have treatment limitation decision making. But it came a little late to us, but come it must. So in our case, we started to talk about this at the turn of the millennium. We had the first publication on ethics of treatment limitation, 2003. Then we had a first position statement of guidelines on end-of-life care, palliative care, 2005. So Indian Society of Critical Care Medicine has been in the forefront. It took the lead in this field. There were iterations in 2012 and 2014, and now the latest in March 2024. In the meanwhile, the law has been a little slow to evolve, but we have been trying to inform the law. It started with the ISCCM approaching the Law Commission of India in 2006 to produce their first draft bill, the 196 bill. There was another draft bill in 2012 in the wake of the Aruna Schonbock case. See, until that Aruna Schonbock case, all the discourse was on active euthanasia, the right to life, or there isn't any right to life, there's only right to live. So those sort of discussions were there, which were not truly treatment limitation decisions in the day-to-day care of the ICU patient. The Aruna Schonbock case brought this to the forefront when there is no hope for the patient. Can we take off certain supports? So then came the real breakthrough in 2018, where we had the mention of withdrawal withholding being constitutionally valid, and the procedures provided, and also the right to execute an advance medical directive, which was also not thought to be appropriate for our country for the risk of misuse. However, by virtue of our right to autonomy and right to privacy, we can exercise the right to execute an advance will and right to refuse any treatment, whether it is going to be saving our life or not. So 2018 brought these principles very clearly home. However, it got lost in procedural guidelines, which are very complicated and three-tier process. So the ICCM again took the initiative to appeal in 2019, and it came for hearing into back into 2022. And in January 2023, there was a simplified process accepted by the Supreme Court. We had to fight the government, the Ministry of Health, but we could negotiate a process which is simpler. It is not the best, it's not the ideal, but it is simpler than before. It is a two-tier process. So that in a nutshell, where we were and where we've come. Yeah.
Thank you, sir. So my next question to you is, sir, withdrawing life-sustaining treatment has always been a steady path for the medical team, judiciary, as well as the patient kin. What is the current procedure that has been followed for the same?
Yes, now the current judgment as it stands in January 2023 has, of course, validated the decision of withdrawal in certain conditions, certain situations rather. It defines it as terminal illness, okay, where the prognosis is of survival isn't good. Or we have also defined terminal illness through the ICMR, which means that you're in the foreseeable future you see an incurable illness culminating in death. So in such a situation, you can take a shared decision making, firstly within the treating team and then with the family. So the Supreme Court asks us to drive a consensus with the family. Or if you have an advance will, then with the surrogate that has been appointed. And if the patient is not incapacitated, then you can approach the patient also directly. So then there is no big process involved. But as it happens in most cases, 95% of intensive care patients, you have to talk to the family or the surrogate appointed surrogate. So you drive a consensus decision, and this is through a primary medical board. Now, primary medical board is in the hospital, so it can emerge from the treating team. In intensive care, willy-nilly, more than one physician is involved, the intensivist, then there are specialists involved. So the primary board can emerge from this already existing treating team, or else the hospital can set up a panel of 3 physicians, 1 primary physician, 2, they call it subject specialists. We mean specialists, of at least 5 years experience. Now, once they have conferred with the family and they've taken a decision for treatment limitation, then this has to be presented to a secondary medical board of 3 other physicians, right? Not the same set. One of whom has to be nominated by the CMO of the district, and 2 others who have 5 or more years of experience as a subject specialist. Now, the appointee by the CMO is not necessary that they have to be from outside the hospital or from a government hospital, nothing of that sort. It has to be an appointee. Now, it can be from within the hospital, but not existing then outside the hospital. You can form a standing committee so that you don't, every time you don't make an ad hoc committee, right? So these are the interpretations of the judgment. You have this 2-tier process. Now, the decision making by the secondary medical board should be preferably within 48 hours, says the Supreme Court, because of the time sensitivity of the process. Then once this approval takes place, then you have to only inform the judicial magistrate of the first class. You do not have to take any approval. Now, this information can be through electronic process as well. It doesn't have to be through a slow mail. So this is in a nutshell. Okay.
Thank you, sir. you touched upon advanced directives, which is a popular concept in the West. And in our country, it is gaining acceptance, especially in some states. A group of people are definitely, forming advanced directive as part of their decision process. So, what is the legal validity of the same in India, and how is it to be followed?
Of course, following the Common Cause judgment in 2018, it's legally absolutely valid. But there are procedural guidelines which got simplified in the 2023 judgment. In the simplified form, you can execute an advance will at any age, at any time, and you can envisage a terminal illness in which what you want done or not done. Okay? You can write there, and you can appoint one or more people to advocate on your behalf, a surrogate. Okay, so one or more, because only one person is needed. But then, in case that person is not available, the next one takes charge, and so on. Or the person himself or herself is no more, then the next person in the line can take charge. So that is what it is. It has to have the signatures of two independent witnesses, preferably not from the family or from the treating team, right? So this is what is said. And this has to be countersigned or validated by a notary public. Okay, you do not need a magistrate to do so as per the previous, the primary judgment. Now there's or failing which you can have simply a gazetted officer signature. And so this is what it says. So advance will, if it is executed, then it is a great help to know what the patient's values and preferences are. But we are not to just interpret it without exercising any of our judgment. That is not what it is meant. Because many times the patients are unable to envisage fully what the situation might be, and you have to exercise your beneficence and non-maleficence as well. Okay, your duties of care. So that is why it is necessary to talk to the surrogate and then have another shared decision-making process, keeping in mind the values and wishes of the patient and interpreting it in the light of the situation, clinical situation. So that is what you are not to just interpret it blindly or just take it as absolute. That's also very clear from the judgment. But I must tell you, the process that follows is the same whether you have an AMD, valid AMD, or you don't have it. That's also very clear. Majority, even in those jurisdictions where AMD has been around for decades, the majority do not have an AMD. In our country, only, you can count them on your fingers who have it. So therefore, you go the usual route. That is, you talk to the family, and you have a shared decision-making process, consensus process. You elicit the values and wishes of the patient through the family.
Thank you, sir. So it was very enlightening to know about the advanced directives and its existence in India and the legal validity of the same. So we come to another challenge which we face in day-to-day scenario about the families in India. So how do families typically take these decisions of end-of-life care decision when it comes to their own loved ones? And what are the common considerations and which we need to keep in mind when we are telling a family member about their loved one is nearing end-of-life care?
You see, it's our duty to make the families prognostically aware. See what I mean? You have to give them as honest a picture as possible and as understandable as possible. See what I mean? You may give, the way you communicate becomes extremely important, and that's where the whole skill is. Firstly, you have to prognosticate thoughtfully, which is what we have named it as reflective prognostication in our ISCCM IAPC guideline, the current guideline. It has to be reflective. You have to see whatever you're proposing, what is the appropriateness of it? Okay. In the light of the prognostic awareness. And that has to be discussed with the family, not just simply physiology, not just simply the disease, okay? How it fits with the current status of the patient, the current trajectory of the illness, and then that has to be married with the values and wishes of the patient. This is called a very thoughtful process and goals of care setting. Okay, so if you do this, then families are helped in making a decision. If you don't do this, they feel very, very incapable of taking any decision, and they may take a route which is a path of least resistance, rather than the correct one. So it's very important that we don't place the onus on the family alone. We have to place the onus on us as well. What is being told, how it is being told, and how it is being understood. So ask, tell, ask is the technique. You ask what you've understood, then you tell, you fill the gaps, then ask again what you've understood. So this is the principle of communication. So it rests very much on the communication. But having been well informed, whatever the family chooses, whether to continue or to do treatment limitation, that should be respected by the physician group. Because we are not here to coerce them into any decision. We are not here to impose our will or what we would choose. It is what the patient would choose as represented by the family. That is the principle. So you give them the option, the choice. The option of comfort care, only choice. Having discussed the available treatment options at that particular time of disease trajectory.
Thank you so much, sir. I think there was a message well said. Having, all physicians needs to be taking care of patients and the family, and the shared decisions is one thing which always consensus shared decision makes a difference. End-of-life care practices and policies are moving in a positive direction in India. Your messages are very clear. And it is responsibility to have this message goes down in the next generation also. For that, training in end-of-life issues should be a part of postgraduate curriculum and super specialty courses. How do you suggest we can achieve this?
Oh, it's a very, very important issue you have raised, Jacob. You see, the training is everything. We have a great gap in training in these issues not only at the undergraduate level, at the postgraduate level. See, our grounding in ethics of intensive care is almost non-existent. We just catch some smattering of information, but we are not formally trained in ethics. Okay? So the ethical awareness, discussion, in-depth discussion of the ethical principles and ethics beyond the four principles also, these things have to be discussed, and then they have to be brought into the bedside situations, right? Because there can be conflict between two principles. And autonomy, beneficence may conflict, or distributive justice and autonomy may conflict. Beneficence and non-maleficence may conflict. So we need to discuss. Discussion is one part of education. Number two is communication. As I said, communication generally in critical illness is challenging, but in the context of end-of-life care, it has to be really honed. So how you communicate, where you communicate, and how you document at every stage of communication, the content of communication, then the supportive therapeutic aspect of communication, which is supporting the emotion, acknowledging, supporting emotion, using the right words sensitively so that you don't aggravate anxieties and all that. You reduce anxieties, the techniques of reducing anxiety, empowering the family, empowering the patient, all those skills of communication, they come through workshops, they come through role models, observing the role models, and also role playing. as a technique of training. And lastly, training also involves as a team, right? You see, it's not just one-on-one training, it's training as a team as well, because this is all teamwork. The nurses have to be with you, the paramedics will have to be with you, your junior and seniors must have a similar culture, okay, of approach.
Thank you so much, sir. I think your message is very clear that importance has to be given for training end-of-life case right from the postgraduate level training in our students. So our last question is, what are the key areas of improvement end-of-life care in India? How do you move forward?
You see, we are at a very early stage of looking at end-of-life care. We have a whole lot of the whole vast sea opened up before us. So one of the most important areas of research is data. See, what is the reality on the ground? Okay, we have a snapshot of the reality in the INDICAP 1 and 2, that there is no formal, well-executed treatment limitation plan, across India. Mostly it is LAMA, which is not really end of life. It is an abandonment. It's not really treatment limitation. It is a sign of frustration. It's a sign of our own incapabilities of handling ethically and finding the right legal framework. So we have to start from scratch. We have to first up. There are already surveys of physician attitudes, okay? Physician attitudes are very clear that we want a mechanism for treatment limitation. Majority of us want, that has been very amply clear. But the next step is the interventional side. Exactly how many withdrawal withholding are happening, how many cases are happening, and what is the mechanism of happening. So for all this, we need formal documentation. So we need evidence-based data collection, okay? And independent sort of adjudication, sort of what is happening, rather than a volunteered information. That is one aspect. Number two, we know that end-of-life care or care of the terminally ill leaves a lot of room for improvement. So we want to know exactly how we are assessing pain, discomfort, dyspnea, thirst, and all those symptoms towards end of life, how we are handling it, how we are using the drugs, how we are de-escalating drugs. It's not just the interventions, mechanical interventions. It's also the use of drugs like antibiotics. We can also do research on how de-escalating appropriate time, how does it impact cost? Okay, because so much is out-of-pocket expense. How does it impact? We need to know hard facts. We have very few studies in this matter, but they are all pointing clearly towards reduction of costs. Then costs in terms of emotional burdens. We need to have actual data of what is the HAD score, anxiety depression score in the families, amongst the families, and what happens to them when we are led carefully, okay, through proper communication. The usual care versus the trained personnel doing communication. So these sort of research is very, very important. Then lastly, we must do research of awareness of the law, right? It's been changing, but very few seem to know even the fact that we can execute an advance will. Even doctors themselves don't know. So we need to know the impact of the judgment, both amongst the professional groups and in the society, and that will show you where should our interventions be. So broadly, this is what it is. There are some questions, about 10 of these questions, research questions, have been listed in the ISCCM IAPC guidelines as well in the last section. Please, those interested can go to.
Thank you so much, sir. Thank you for enlightening us about the end-of-life care issues and addressing the several challenges which we face in practicing end-of-life care in India. I think each and every question was dealt with so much of enthusiasm, and your answers were extremely clear. Thank you, everyone, for joining us for this podcast. Thank you.